And so we're fortunate here to have Dr. Levi Hill, who's has his doctorate in pharmacy and is working intimately with the team in the management of what we are calling the anti-amyloid therapies, or what you may see in your notes is written as AAT. So the anti-amyloid therapies is the next generation of ways that we can hopefully slow down the disease processes by targeting those misfolded proteins that Dr. Nelson mentioned, particularly amyloid. And we also know that it has other impacts on tau and other proteins down the line. Thank you very much, Doctor.
Good morning, everybody. Can we hear me fine? I think I can hear me too. Yeah, thank you for the introduction. I want to do a special shout out to Mary and Dr. Nelson. Like Dr. Houghton said, it's really important to understand the context behind how these diseases develop, how they progress, as well as understanding what you might see, so that, lecture on cognitive impairment beforehand. I am going to take some time today talking about I think this is the way that this goes. Yeah. I'm going to take some time today to talk about, really, we can think of this in like 3 different buckets, I think. We can talk about what is happening now, what we're actively doing, specifically to be treating Alzheimer's disease, what is in the works, what's looking promising, but is not quite ready to be used just quite yet. And then I want to make sure that you all have good takeaways for what you can do for yourselves, ways to think about these treatments and them as options for you. So piggybacking off of why this matters, I think it's important to understand a bit of the history behind where treatment of dementia and Alzheimer's disease has historically been. So for the last, really forever, since we've had treatments for Alzheimer's disease, we've really focused on symptomatic treatment of our patients. So we have trouble with memory, we're going to use medications to help with memory. We have medications that can help with other things as well. So we do those symptomatic things. Until recently, and by recently, we'll see in really the last 4 or 5 years, we've been able to make strides in slowing down the progression of Alzheimer's disease. This is huge. This has been vetted in the literature. It's new. And biomarkers that Dr. Nelson had spoken about are really what's helping us guide who is a good candidate for these medications. So it's a combination of not just we have a medicine, we can use a medicine. It's really everything involved, right? Now, with that progress that we've made with this medications that we have now, there are additional complexities. We want to try to get patients in and screen them as early as possible, diagnose them as early as possible. It's also important to set expectations that the medications that we have currently are not a cure by any means. They don't necessarily reverse what's already been done, and they may not be the right fit for everybody in the room. And I think that can be a difficult conversation, but an important conversation, and understanding that the success of the treatment itself really depends on matching the right person with the right medication at the right time. Just a little bit of an understanding behind how we look at Alzheimer's disease. We mentioned in the previous lecture, there's amyloid pathology, there's that amyloid buildup, there's tau pathology, there's that tau buildup, and we also eventually have this neurodegeneration or neuronal injury. This is almost, we call it an ATN framework. This is how we understand in our patients that we are seeing, we are assessing, where they are at almost in this disease process. Do they just have this amyloid buildup? Do they have this amyloid buildup and this tau pathology? And do they have this injury? All of those things come into play, and right now are helping us pick which patients are going to be good candidates for the anti-amyloid therapies that we're going to spend a large portion of this lecture discussing. Now, we've mentioned this as well, that amyloid often begins to build up years before patients start to experience symptoms or before we see them in the clinic, whereas tau accumulation, as well as this neuronal injury, usually tracks with how patients are declining. So what we have for treatments right now, anti-amyloid therapy, is targeting this amyloid buildup. I also think it's important to think about where we are at and where we came from with anti-amyloid therapy specifically. Drug discovery and the approval of medications is a long long process. Can take years, can take decades, depending on what's being treated, what we're looking at, what the outcomes are, et cetera. We start with drug discovery, thinking about our scientists that are in private labs, public labs, that are trying hundreds of different compounds to see what's going to have an effect on a certain protein, what's going to have an effect on a certain part of the body, to get some understanding that this interacts with that. Once we have that, we can move into our preclinical research phase. Our preclinical research phase is where we're doing test tube testing, animal testing, to ensure that these medications are not entirely toxic to whatever we're trying to treat, right? Once we've determined that these are safe enough to test in humans, we move on to human trials. We have 3 different phases of pure clinical research, going from young, healthy patients who are just exposed to the medication, all the way to hundreds of patients living with the disease we're trying to treat. Those treatments, those studies are done to assess if the medicine really is effective, usually against a placebo, or, well, in addition, I should say, to any negative effects. What side effects do patients have? How severe are those side effects? How often do these side effects show up? All of these things come from clinical trial data. So you may hear your providers talking about, well, this is what we know because of the clinical trials. This is what the clinical trials show. These are real world data that we have that support the use for these medications. After we have clinical research completed, we move on to FDA review, where there's a panel of scientists and physicians that review all of the data to determine if this is safe enough to get put on the market. Not only is it safe enough, is it effective, right? We're not going to put something on the market that doesn't work. So after that, that's not where things end. We're constantly doing post-marketing research and monitoring to ensure we're getting the full picture. A lot of clinical trials, especially the ones that are done for the anti-amyloid therapies, initially were done over an 18-month period. 18 months is a long time to be getting an infusion, but 18 months is not the rest of somebody's life, right? So we continuously are gathering data about side effects, gathering data about how effective these medications are, so we can continue to build this body of literature to continue to support the use of these medications. So we're always researching these, we're always gathering more information. With anti-amyloid therapy, we didn't have a lot of success in the beginning. A lot of the trials failed to show any meaningful benefit to the patients that were exposed to the medication. A lot of studies that were done, unfortunately, had poor patient selection, so they didn't necessarily have the right stage of the disease to be targeting amyloid. Again, earlier stages is better, we'll see that later. Or we didn't have confirmation that they had amyloid disease, back to that ATN framework understanding that that amyloid pathology needs to be present. Thankfully, over time, as the scientific community has progressed, we've learned things. We've been able to have better antibodies and better patient selection. So we know that by choosing the right patient with the right type of disease, we can have these modern approvals come through. And in fact, did I skip? I think I skipped one. Yeah, we have these modern approvals come through. Now, the current landscape of Alzheimer's disease research is actually improving. There are more and more studies coming out every year. As of today, only 2 agents are approved for the treatment of Alzheimer's disease, slowing down the progression of Alzheimer's disease specifically. We're going to talk about those 2 today. There are, in 2025, a total of 182 clinical trials that are looking at different treatment options for Alzheimer's disease, which is an improvement from 2024, where there are 164. So this is just an area that's continuing to grow in the research sector. We're looking not just at amyloid, we're looking at medications that can affect tau. We're looking at medications that can provide even more meaningful symptomatic management as well. I have this here. I think you can all see my... Yeah. This is a graphic I got from a study that just highlights different areas that are being studied, but you can see just the vast amount of medications being studied. Each dot is a different medication. So we're doing a lot of research in Alzheimer's disease specifically. I have alluded to anti-amyloid therapy, but now let's get into the nitty-gritty. So anti-amyloid therapy uses antibodies administered to patients to help the immune system clear amyloid plaques from the brain. That is what it does in its most basic form. The different mechanisms that it can produce this effect are in this photo here. So we can have direct binding of that antibody to these plaques that then begins to untangle them. They start to break apart on their own. We can also have these antibodies flag these plaques for the immune system that we have in our brain to start getting rid of those plaques via the immune system. So we have some help from the immune system there. We also have another mechanism called the peripheral sink mechanism. This is looking more so at any plaque that maybe has already been removed from the brain in our natural processes, is being grabbed by these antibodies, which then causes a pool to pull more of those plaques into the bloodstream. So a sink, right? Open the drain, stuff goes through. Those are the three different mechanisms of which we understand these medications are working currently. The two medications can target the soluble amyloid aggregates or protofibrils. These are more of those like invisible pieces of the plaque that are building up. We can also get insoluble amyloid plaques, the ones that we can actively see. Those can be targeted as well. The effect of these treatments is to decrease the amyloid burden in the brain, as well as decrease the rate of cognitive decline. So we're seeing, through this slowing of disease progression, we're seeing real disease-modifying activity. But please note that it does not reverse what's already been done. It does not reverse existing damage. The two treatments that are approved for Alzheimer's disease slowing of the progression are lecanemab and donanemab, both approved in the last 3 or so years, targeting those soluble protofibrils as well as the insoluble plaques. Lecanemab is given every 2 weeks. Donanemab is given every 4 weeks. And we have an understanding of how much those plaques are going to be decreased over the course of 18 months, again, based on our clinical trial data. Centiloid reduction is the term in which we use to describe how much of those plaques are being removed from the brain. For lecanemab, we see about 50 to 60 centiloids reduced over the course of 18 months, and in donanemab, up to 90 centiloids reduced over 18 months. These are the first treatments that have been approved for Alzheimer's disease in 20 years. Again, that is a huge progress for Alzheimer's disease. Again, they're helping to target the underlying biology, removing those plaques, and by removing those plaques, helping to slow down that tau accumulation that happens later on in the disease progress. This photo here shows in the red the sheer amount of amyloid plaque in this patient's brain before treatment and after treatment. It doesn't take a neurologist to see that there's a pretty big difference, right? Huge difference. Now, I mentioned that amyloid removal is associated with slowing that tau spread. By slowing that tau spread, that's where that disease-modifying activity comes through. That's why we see what we see. Disease modification happens, it's real, but it's modest. Note again that it slows the clinical decline, does not restore memory, but it does delay the worsening of this decline. So we get meaningful benefit, but it's not going to be like night and day. What we see in the clinical trial data, Clarity AD was the landmark trial that was done for lecanemab, big trial that got it approved essentially. We saw 27% slowing of disease progression with Alzheimer's disease. Trailblazer-ALZ 2, which is for donanemab, its landmark trial that really led to its approval, we saw between 20 and 35%. 20 and 35% disease slowing. Now, note that the percentage that is reported is an average across all of the patients, all the hundreds of patients that were in this trial. Some patients had a larger response, more than 27%, more than 35%. Some patients had a lower response, less than those numbers. So the way in which you may respond or a loved one may respond to these treatments, we think is dependent on variables we just don't know yet. We just don't know yet. But then that begs the question, well, who's going to benefit from this therapy at all? The things that we do know is that patients who are early in their disease progression, who have low rates of tau, are going to have the most benefit. So where I mentioned that early diagnosis, that early management is vital, it's vital because of what we saw in these trials. I have here some graphs that do show the top left-hand corner, the clinical dementia rating score here. You can see that that dotted line, higher numbers are associated with worse cognitive function. And so as that number goes up, that's what's happening in the placebo group. You can see that drastic difference with that number at the bottom, right? That line at the bottom is much lower. And on the bottom, we can see here between two groups that were in the treatment for donanemab. On the left-hand side, patients that had low amounts of tau had a higher rate, or had a slower rate of decline, 35% roundabout for patients who had low amounts of tau, 35% slowing versus lower in the higher groups. With treatments and with effectiveness comes safety concerns. Our most common side effects of these are infusion-related reactions and headaches. But the key risk that we look at and we're monitoring with these treatments is known as ARIA. ARIA stands for amyloid-related imaging abnormalities. ARIA can be split into two different types. We can have ARIA-E, which is brain swelling, and ARIA-H, which is microhemorrhages, H for hemorrhage. I have some MRIs on the left-hand side here. Yeah, left-hand side. All the way to the left, labeled ARIA-E, you can see those hyperintensities, those lighter gray areas. That's the ARIA-E that we may see on somebody who has ARIA-E. This is a pretty severe case of ARIA-E, but it's good for showing. ARIA-H itself, and this arrow did move, so I'm going to try to point as best I can here. Okay. ARIA-H, what we see are the almost tiny pinpoint. It looks like if you took a pencil and just dabbed it on a piece of paper. That's how it looks on an MRI. So it takes a good neurologist to be able to catch these. But these areas here, if you can see these pinpoint areas, this is considered that ARIA-H, those microhemorrhages. So what does this look like in reality? Is that patients generally are asymptomatic and they resolve on their own, and we facilitate the resolution with monitoring. So we already are doing monitoring for these infusions regularly, especially in the first 6 months, but we will be hyper vigilant. We will monitor these like crazy in patients who have one of these two conditions as a result of treatment. So know that though this is a risk, it's manageable. We manage this relatively frequently, or at least as frequently as it comes up. Now, I have here some real-life data that we have from our patients here of what we have seen in terms of these side effects. ARIA is a risk in and of itself, but as you will hear about later today with CAA, we do believe that there is an increased risk for developing this in patients who have underlying CAA, underlying cerebral amyloid angiopathy. Now, with that being said, in addition, this insight comes from the clinical trials that showed spontaneous microhemorrhages from patients who were not on the treatment of Leqembi or the treatment of Kisunla. Those medications, patients that were not on them still had this, what looked like ARIA-H. And so this suggests that maybe something else is going on, something that presents similarly the CAA. Now, the trials themselves, top left-hand corner, this graph here shows the lecanemab treatment versus placebo, rates of ARIA-E and H. You can see that in ARIA-E, there were higher rates of, in the lecanemab group versus the placebo group. But in the red, you can see that there was still a pretty high amount of ARIA-H in the placebo group. And the same really looks for donanemab as well. You still see higher rates of that ARIA-H. Again, telling us maybe something else is going on. Maybe it's this underlying CAA. Because of that, we at Ochsner have started to approach patients starting anti-amyloid therapy with screening. We want to screen patients to see if they have CAA. We want to screen patients to see if they're at a higher risk of these brain bleeds. That has helped us to determine what the best option is for medications. That has helped us to put patients with providers that are comfortable with discussing these things. And again, that hypervigilance, helping us make sure that we're having touch bases with these patients that are our higher risk patients. Now at the bottom left-hand corner, I have both percentages of ARIA-E and ARIA-H from the clinical trials, and also what we have seen from our patients here at Ochsner. Far left-hand side, we have the donanemab, based on the studies, rates of ARIA-E and ARIA-H. From left to right, you see that that starts to trend down with lecanemab coming through with standard dosing right in the middle. And then a rather large jump down from here at Ochsner with patients who are getting standard lecanemab for rates of both ARIA-E and ARIA-H. Patients that are at lower risks of developing these is right beside that. So lower rates of ARIA-H, lower rates of ARIA-E. And then we've seen that our patients who are on donanemab have had no reactions at this point in time from when we did this data pool. Again, we believe that this is because of that screening that we do, the counseling that we do, putting patients in these higher risk clinics to ensure that we're doing what we can to prevent this as much as possible. In reality, our infusion-related reactions are about 7%, ARIA-E and ARIA-H 4 and 8%. But we're seeing what we saw in the trials. Consistent decline in the amount of amyloid in the brain, a decrease in the amount of tau that we see in the blood, and a slowing of clinical decline. Again, greatest benefit occurs early on in treatment, but it's not the only thing that we're doing. We still need to keep an eye on sleep, diet, and exercise. We still want to treat some comorbidities, things like vascular disease, things like hypertension. And we also want to make sure that our patients have this longitudinal support to get all the way through treatment and to get whatever help that they need. With this comes the understanding that the infrastructure matters. The infrastructure of the institution you're at matters. This is not just you go to the doctor, they prescribe you this medication, and you're good to go. You have to get counseling, you have to get imaging, you have to figure out if your insurance covers the infusion. How do you get your insurance to cover the infusion? How do we get these MRIs? How often do I follow up with these patients? So here at Ochsner, we really believe that it's a multidisciplinary approach. We have a lot of people involved in ensuring that our patients are getting the best care that they can with these infusion therapies. So based on this, if you feel like maybe you would be a good candidate or you want to learn more about anti-amyloid therapy, I'd suggest you talk to the neurologist that you see regularly. To wrap up a little bit about the anti-amyloid therapy is talking about expectations. Note, again, it's not a cure. It is not a treatment for advanced dementia, and it may not be appropriate for every patient, and that the best results occur in patients who have an early diagnosis, who have mild disease, who have confirmed amyloid pathology, and who have close monitoring with their providers. As we move forward in the scientific process, as we come up with new treatments for Alzheimer's disease, it won't just be surrounding amyloid. We already talked today, again, about that tau accumulation. We're going to want to try to find ways to help with that accumulation there. We're maybe going to want to try to find ways to get our neurons to communicate better with each other. So looking at things like circuit dysfunction, synaptic failure, inflammation, and other proteinopathies are going to really help us to understand and better treat in a more individual way for our patients what they're dealing with. So that's a really, really exciting place to be in the literature and in the scientific community, is finding ways to make big differences. I'm going to go briefly through a few more therapies that are newer. The first one I want to talk about is an anti-seizure medication called levetiracetam. This is not a new medication, but its implications in Alzheimer's disease is new. So what we see in one of the memory centers of the brain is, and sometimes patients have a hyperactivity of that network. And so that can be associated with faster decline of cognitive function. We can use this anti-seizure medication in patients who have this hyperexcitability to stabilize, which we then have seen in clinical trials can improve memory and task performance. Overall, what we see is that for all patients with mild dementia, it may not be a beneficial medication, but for those patients who specifically have this hyperexcitability, it can be beneficial. Our next treatment looks at alpha-synuclein in Lewy body dementia. So we already had seen from Dr. Nelson's presentation that there is a stressful communication in some of those synapses as a result of this disease. Neflamapimod is a new medication that is helping to streamline that communication between these neurons. And by streamlining that communication between these neurons, the hope is that the different domains of cognition can be improved. What has been seen in phase 2 clinical trials with neflamapimod is an improvement in the dementia severity and the dementia and mobility for patients. Attention and executive function, generally speaking, are the most responsive. And for patients that have pure dementia with Lewy bodies, we see the best benefit. So I will say this is still an investigational medication. It's not being used yet, but we're actively gathering some information, and we think that synaptic support therapy is probably going to be beneficial for a lot of our patients with neurodegenerative diseases. All right. Last new treatment I want to talk about is an entirely novel new mechanism called VTX002. Looking at patients who have an accumulation of this TDP43, specifically in the frontotemporal dementia, what we see here is a new way to have the immune system or have the neurons in our nervous system produce an antibody against those. Historically, it's been difficult to get medications into the brain because of that blood-brain barrier. It's very protective, very tight. What we can utilize are harmless viruses that can go into the brain and can add genetic material to the neurons. By adding this genetic material to the neurons, we're able to have that neuron on its own produce these antibodies that can then target this misfolded protein and clear it out. That's the idea behind this. Very cool, very new. Very early on, phase 1 and 2 trials, we don't have any human efficacy data, but it's a very promising way to treat a very difficult to treat disease. Kind of alluded to this, but the future of neurologic care, especially neurodegeneration, is going to be multiple different therapies. Kind of thinking more of an oncology approach where you kind of target this, you target that, target this, to make sure that the whole patient's taken care of. So beyond just this amyloid, we'll look at inflammation and other proteins that could be causing problems. I think what's important for families to hear today is that the treatments that are available are progress, but not a cure. The benefit is slowing and not restorative. Some patients are good candidates and some aren't. And that decision comes with understanding and a discussion with your neurologist. Again, we have real advancement here today. Patient selection, safety monitoring is important, and the future of dementia will be much more precise over time. Thank you all.
Thank you, Levi.